but was not able to make it. So I have to sit in for him. My name is Stephen Isiado, from Ghana, Senior Specialist in Public Health and the Program Manager for the National AIDS Control Program, a member of the Scientific Committee for ICASA. So I'm here to sit in and to facilitate this program. We've lost some time, but we're going to make sure that we catch up as we take some brief presentations from our panelists. And it's my pleasure, ladies and gentlemen, to introduce our panelists for today. The first is Jody Dimitri Ondo from Gabon. He will be speaking on HIV drug resistance in Gabon. And then Dr. Nkazimolo Chuma, who is with the AIDS Healthcare Foundation in Zimbabwe. He is the medical director at Impilo Center of Excellence, and he'll be talking about HIV-related mortality. So, ladies and gentlemen, for those who need translation, please get a cord from the back, because Dr. Ondo is going to speak French. So let's put our hands together and invite him to start. So, Doc, go ahead. Translators, please bring me one headset. It's not done. No.
Good afternoon to you all. I really appreciate this opportunity that I've been given to present our analysis that we did, that is entitled Causes and Clinical Determinants of Mortality Among People Living with HIV at Impilo Center of Excellence in Bulawayo, Zimbabwe in 2022. Next slide. That will be my presentation outline. Next slide. We know that globally, mortality trends have been declining since the introduction of antiretroviral therapy. According to UN AIDS, AIDS-related deaths have been reduced by 69% since the peak in 2004, and there has been a further reduction since 2010. However, in the resource-limited settings, mortality remains significant, especially in sub-Saharan Africa, and Zimbabwe is not spared. Of note is that the rate of mortality decline in Zimbabwe between the period of 2010 to 2015 was around 53%. However, it sort of like slowed down between 2015 and 2021, and it went down to 33.3%. However, of note, we need to appreciate that non-HIV related causes of mortality are becoming an important contributor. Therefore, there is need for monitoring of causes of death in people living with HIV so that we'll be able to craft interventions to reduce mortality. Next slide. Specific settings at Impilo Center of Excellence in the period of January to December 2022, we had 129 documented HIV-related deaths. This is 507 clients who were seen during the same period. And if we were to look at the rate of mortality there, we documented 13 deaths per 1,000 people living with HIV. Therefore, we saw that there was a need to characterize the causes of mortality. Next slide. Our study objective was to identify the causes of death and clinical determinants for mortality at Impilo Center of Excellence in 2022, And specifically, we wanted to determine the demographic and clinical characteristics related to this mortality. We also wanted to determine the causes of mortality in pre-art and art clients. And lastly, we wanted to determine the contribution of non-communicable diseases in this cohort. Next slide. So the methods, this was a cohort study with secondary data collection done at Mpilo Center of Excellence, which is an urban clinic which offers HIV management, prevention, and care. And as I said, in 2022, we saw a total of 10,507 clients, and our study participants were people living with HIV who were registered at this facility and subsequently died in 2022. Our data was collected from the electronic patient management system, from the OI care booklets, from the clinical notes, and also from our defaulter tracking and tracing register. This data was abstracted into Excel and further exported into AP Data Analysis version 3.1, where we then generated frequencies, proportions, and measures of central tendency and spread. Next. Next. Then on to our results. Those were the demographic characteristics. Our median age in this cohort was 44, then males and females as shown there. However, this was not statistically significant. Next slide. This slide shows age disaggregation according to gender. So the blue bars represent males and the gray bars represent females. The graphs are a bit similar, but of note is that among the 10 to 19 age band and also 30 to 39-year age band, the mortality was more common among males as opposed to females. However, the 20 to 29 age band mortality was common among females. Next slide. Then mortality and antiretroviral therapy status. So in this cohort, 37% of our mortality was among the pre-ART clients and 63% was among those who were on ART. And the breakdown was as shown. For pre-ART, we had more commonly males as opposed to female, then vice versa among those who were already on antiretroviral therapy. Next slide. So this slide shows the causes of mortality among the pre-ART clients. Of note is that pneumonia, TB, and meningitis remain the predominant causes of mortality. And also what we need to note is that we had quite a number who had NCDs-related mortality. And out of those who were on pre-ART, we had 2 where we couldn't ascertain the causes of death. Next slide. Then in terms of CD4 count at baseline for our pre-ART clients, as I said, the total was 48. Among the 48, 27 had documented baseline CD4 count, and out of the 27, 20, which makes 74.1%, had a CD4 count of less than 200, which means they actually had advanced HIV disease. This is not the only proportion of people that had advanced HIV disease. We also had 18 who didn't have a baseline CD4 count, but clinically they had conditions that put them into stage 3 and 4. So which means our total proportion of clients who actually had advanced HIV disease at presentation was 79%. Next slide. Then let's go on to causes of mortality among clients who were already on antiretroviral therapy. Again, we note that pneumonia, TB was the predominant cause of mortality. However, with this one, meningitis comes fourth. We note that renal failure and cancers caused significant mortality as opposed to the pre-ART clients. Then the other conditions, as we can see, were mainly non-communicable diseases. We also had 4 clients where we could not ascertain the cause of mortality. Next slide. In terms of viral load coverage among those clients who were already on antiretroviral therapy, we had 58 who had been on antiretroviral therapy for more than 6 months and therefore were eligible for viral load. However, only 47 had the documented viral load result at the time of death. Then out of that 47, 55.3% were virally suppressed with a viral load of less than 50 copies. 10% had low-level viremia, which is a viral load of 50 to 999 copies, and 34% were unsuppressed with a viral load of more than 1,000 copies. So we note that majority of these had viral suppression. Next slide. Then if we were to zero in into the viral load in NCD-related mortality, we note that those who had NCD-related mortality were 26, and out of the 26, 21 had the documented viral load results. And again, with this one, we had 66% having a viral load of less than 50 copies, so they were virally suppressed. Low-level viremia, it was at 14%, and those who were not virally suppressed were 19%. So again, the picture is similar. Majority of them were actually virally suppressed. Next slide. So my last slide on results talks about the ART regimens that the recipients of care were on at the time of death. So we noted that most of the mortality was among the recipients of care who were on first line, followed by second line, and we only had one who was on third line. Let's move over to our challenges. Next slide. So our limitations in this analysis was that we noted that there was suboptimal documentation in the clinical records, so much that, as I mentioned, there were some unknown causes of mortality, especially for those who died at home. We could not really ascertain what was the cause of mortality. Next slide. So in conclusion, we note that TB, cryptococcal meningitis, and severe pneumonia remain the predominant causes of mortality among people living with HIV, and also that majority of the clients were actually virally suppressed at the time of death, and also non-communicable diseases are an emerging important contributor towards mortality among people living with HIV. And lastly, despite the introduction of Treat-O in 2016, we note that advanced HIV still contributes significantly towards HIV-related mortality. Therefore, based on this, our recommendations, next slide, we recommend that we strengthen community engagement in timely HIV testing and linkage to care so as to reduce the rate of advanced HIV disease among people living with HIV. We also recommend integration of HIV with routine screening and management of non-communicable diseases at the HIV clinics. And also we recommend that more large-scale studies to be done to ascertain the trends of mortality in people living with HIV, especially in developing countries, so that we are able to tailor-make interventions that will respond to our local context. Lastly, we recommend strengthening of documentation so that we'll be able to use the data for data-driven interventions. Next slide. Those are my acknowledgements. I thank you.
Yeah, thank you very much for the appreciating here. So please note all your questions. I will come to the question time. So let me invite our next speaker to take the floor. Monsieur, proceed. Can we have the slides rolling?
Ok, merci. Donc, nous allons parler de la suppression virologique et de la résistance du VIH chez les patients infectés par le VIH sous thérapie contenant du dolutegravir au Gabon. Next. Next. Donc, l'émergence de la résistance aux antirétroviraux constitue aujourd'hui une menace pour l'efficacité des traitements antirétroviraux. Next. C'est pourquoi l'OMS, en 2017, donc, a formulé le Global Action Plan of HIV Drug Resistance pour les pays. Et dans ce rapport, l'OMS propose de mener des enquêtes sur la résistance en surveillant les indicateurs d'alerte précoce tels que la charge virale plasmatique. Next. Ces enquêtes donc, nous permettront de vérifier la performance des traitements. Next. Donc la performance des programmes relatifs à la thérapie, mais aussi de prévenir, suivre et riposter contre la résistance, dans le but, bien sûr, d'atteindre les objectifs fixés d'ici à 2030. Next. Par ailleurs, en 2019, suivant le rapport de l'OMS sur la résistance aux inhibiteurs non nucléosidiques, l'OMS a recommandé que les pays en voie de développement, comme le Gabon, mettent dans leur traitement antirétroviral, en première ligne et en deuxième ligne, les traitements à base d'inhibiteurs de l'intégrase. Next. Au Gabon, pays de près de 2,3 millions d'habitants, la prévalence du VIH est de 3,6%, avec 54% des PVVIH sous traitement antirétroviral. Et next, depuis la recommandation donc, de l'OMS, le Gabon a revu ses lignes thérapeutiques en fixant comme traitement depuis 2019 2 inhibiteurs nucléosidiques plus un inhibiteur de l'intégrase, à savoir le dolu. Next. Donc cette recommandation de l'OMS peut être appuyée par une étude que nous avons réalisée au niveau du Gabon où nous avons rapporté un taux de mutation de résistance aux inhibiteurs non nucléaux à plus de 80%. Il s'agissait donc de la nivirapine, de l'efavirenz. Next. Cependant, depuis l'introduction des traitements à base d'inhibiteurs de l'intégrase au Gabon, aucune étude n'avait été réalisée dans le but de vérifier l'efficacité de ces traitements à base d'inhibiteurs d'intégrase. Next. C'est pourquoi donc next, nous avons donc déterminé notre objectif comme étant le but de déterminer la réponse virologique chez les PVVIH qui suivent un traitement à base de DTG et étudier l'impact de la résistance préexistence aux inhibiteurs nucléosidiques chez les patients sous tenofovir, lamivudine, dolutegravir. Next. Plus spécifiquement, il fallait donc déterminer le taux de suppression virologique, déterminer le taux d'échec viraux, identifier les mutations aux inhibiteurs de l'intégrase et aux inhibiteurs nucléosidiques et étudier l'impact de ces mutations sur le traitement. Next. Donc, nous avons réalisé notre étude dans 3 centres de prise en charge du VIH au niveau du Gabon, distribués dans 3 provinces, au nord et au sud-est du Gabon. Les analyses biologiques ont été toutes réalisées au Centre international de recherche médicale de Franceville. Next. Donc, de décembre 2020 à mai 2022, nous avons prélevé des PVIH pris en charge dans ces différents centres de Franceville, Koulamoutou et OIM. Comme critère d'inclusion, il fallait être sous traitement à base de DTG depuis au moins 6 mois, être adulte et donner son consentement pour participer à l'étude. Next. Après prélèvement, donc les patients étaient prélevés sous tube EDTA, l'extraction était faite à l'aide du kit de Chiagène, la charge virale avec générique HIV viral, le protocole PCR suivant celui de l'ANRS AC11, le séquençage avec la méthode de Sanger et la phylogénie suivant le logiciel MEGA. La recherche des mutations de résistance a été faite donc, à l'aide de l'algorithme de Stanford. Next. Donc, au terme de nos analyses, nous avons recruté au total 423 patients. Next. Avec les femmes qui étaient prédominantes et l'âge médian était donc à 50 ans. Nous avons rapporté un taux de suppression virologique de plus de 80%. Nous avons rapporté peu de mutations de résistance. Celles qui a été rapportées, donc, il y avait des mutations aux inhibiteurs nucléosidiques avec la M184V, la T215F, la L210, la M41L, et aussi des mutations aux inhibiteurs de l'intégrase, notamment la L74I, la E157Q, la P145S et la R263K. Next. Après analyse phylogénétique, nous avons donc confirmé que le sous-type prédominant est bien le CRF02AG suivi du A1. Next. Un patient dans notre étude était porteur d'une part des mutations aux inhibiteurs nucléosidiques de la transférase inverse et aux inhibiteurs de l'intégrase. Ce patient était un échec virologique avec une charge virale de plus de 10 000 copies et son sous-type était le sous-type C. Next. Donc, faisons suite à nos résultats, nous pouvons dire qu'avec les schémas tenofovir, lamivudine, dolutegravir, nous pouvons obtenir des taux de suppression virologique assez importants, contrairement aux anciens schémas distribués au Gabon, que lorsque nous avons rapporté notre dernière étude qui était à moins de 50%. Donc ces schémas nous permettront bien évidemment d'atteindre les objectifs de l'ONU-SIDA. Cependant, nous avons constaté une émergence de la résistance au DTG. En effet, nous avons détecté la mutation R263K chez un patient en échec viraux. Cette mutation réduit à 2 fois la sensibilité du DTG, du bictegravir et du cabotegravir. Et cette mutation a été rapportée dans plusieurs autres études où le DTG causait un échec virologique. Next. Alors, pour expliquer, nous avons formulé une hypothèse pour expliquer l'apparition de l'échec viraux et la résistance chez ce patient. Le patient avait donc la présence des mutations aux inhibiteurs nucléosidiques, notamment la M184V qui a potentiellement réduit la sensibilité de la laméviline. Aussi, la présence des TAMS qui ont potentiellement réduit la sensibilité du TDF. Donc, notre patient s'est certainement retrouvé en monothérapie fonctionnelle du DTG, ce qui a favorisé l'émergence de la résistance au DTG. Thank you. Next.
Can you hear now? Can you hear now?
Okay. Okay.
Hello.
Okay. Donc, nous avons regardé l'impact de la résistance du VIH dans la résistance des inhibiteurs de la transstase inverse sur les schémas à base de DTG. En effet, selon l'OMS, l'évaluation de la résistance du VIH aux inhibiteurs nucléosidiques en cours continuera de jouer un rôle important et pertinent car l'impact de la résistance du VIH aux inhibiteurs nucléosidiques préexistants sur le traitement est encore inconnu. Le traitement à base de DTG, outre sa robustesse et sa performance, peut rencontrer un problème au niveau du Gabon.
Okay, where is the mobile mic? Where is the mobile mic? Please bring it. The interpreter is struggling to hear through the mic, so let's use the mobile mic.
Thank you.
Can you hear now? Right. Okay, proceed.
Okay. Donc, nous disions que nous avions évalué l'impact de la résistance aux inhibiteurs nucléosidiques préexistantes chez les patients qui reçoivent du DTG. En effet, le traitement à base de DTG, outre sa performance, sa robustesse démontrée, peut rencontrer une difficulté au niveau du Gabon et dans des contextes où les mutations préexistantes aux inhibiteurs nucléosidiques dominent, notamment avec la mutation K65R et les TAMS qui peuvent affecter la sensibilité du DTG et la mutation M184V qui peut aussi affecter la sensibilité de la 3TC. Donc, les patients qui recevront le TLD, tenofovir lamévidine, pourront se retrouver donc en monothérapie fonctionnelle à base de DTG et cela pourrait compromettre le traitement antirétroviral. Next. Next. Donc, en conclusion, nous avons rapporté un taux important de suppression virologique en présence des schémas TLD. Nous avons rapporté un faible taux de mutation de résistance aux inhibiteurs nucléosidiques et aussi aux inhibiteurs de l'intégrase. En revanche, nous avons rapporté une émergence de la résistance au DTG. Cette émergence suggère donc un suivi et une surveillance de la résistance chez les patients qui reçoivent le DTG. Et aussi, nous devons mener une étude plus importante pour établir le véritable impact des mutations préexistantes aux inhibiteurs de la transcriptase inverse sur les schémas TLD. Enfin, nous proposons donc d'étendre notre étude au niveau national afin d'aider le programme national de lutte contre le VIH pour une meilleure prise en charge. Je vous remercie.
Well, thank you very much. So you see, the context for this presentation is that a lot of ART programs started about 20 years ago. People are on treatment. And so we have an aging cohort of people who are on antiretroviral therapy. And because they are surviving now, they are also now coming along with age-related potential conditions. So this session is looking at HIV and aging. And that's why the first presentation was focusing on more like a cohort to look at the causes of mortality by comparing pre-ART and then people on ART. And then the second, we're looking at whether there were the emergence of some form of mutations or resistance. And then it is clear that the highlights for the first presentation was that majority of the people died, whether it was pre-ART or ART, from pneumonia, from tuberculosis, and meningitis. All right, and 79% of those who were pre-ART had advanced HIV disease by the criteria. And then also for those who were on therapy, pneumonia, tuberculosis was an issue, renal failure, cryptococcal meningitis. 34% of those were unsuppressed. And AR NCD-related conditions also was there. So this is the context for the highlights for the first. And the second was that though there was slight mutation, was not significant, and the resistance was not significant. Most of the people had good virus suppression in the Gabon experience, but there's a need to follow up on this. So I will open the floor for questions by first of all asking my first presenter, Dr. Chuma, to clarify one or two things for me. The first is that you didn't tell us about the kind of regimen that your clients were on, those on ART. What therapy were they on? You said it's first line, but what first line therapy are you using? And then secondly, in your recommendations, you talked about the need for community and all that, but given the fact that there was TB and all that, what is your TB prevention program like in your country? What is TPT and all that? Because it looks like quite a number of people had tuberculosis. And then the third is to do with the cryptococcal meningitis. Have you adopted the WHO guidelines, the recent guidelines for cryptococcal meningitis in your country? So this will be my the way that I want to open the floor for questions. Can I see by hand? I hope you took note of the questions. Right. So can I see by hand any other interest to ask questions? We will take 3 more, and then we will take. So I will give the opportunity to you here, who is here first, and then we'll go to this side. So please give her the mic.
Thank you. Thank you very much. My question is to Dr. Schumer, and it's closely related to what the chair has asked. It's interesting that meningitis was the 4th killer. You know, we are used to TB and then meningitis, but here meningitis was the 4th killer. So I'm also just interested in how the facility is managing meningitis. And the 3rd leading killer was cancers. Which cancers were these? And were they mostly affecting men or women? Did we see a lot of mortality for the cancers in men or women? Thank you.
Okay, thank you. Straight to the point. Can we have 2 more here, and then we'll get the answers? Yes.
Just to add to your good questions, did you disaggregate by number of years people were on ARVs so that we can also see if there's a trend in certain cancers or whatever that might be appearing with duration of use?
Duration of antiretroviral therapy, and then the third. Yes, go ahead.
Bonjour tout le monde. Je vais poser ma question en français parce que je m'intéresse plus à l'étude qui a été faite sur l'apparition des souches de résistance, notamment sur le dolutegravir. Et l'essentiel de nos pays actuellement sont sur ce protocole-là et que des évaluations pour déterminer le profil de résistance n'est pas encore faites. Maintenant, je suis un peu inquiet pour le patient que vous avez dit qui a développé des résistances et pour le dolutegravir et pour le tenofovir et la lamivudine. Maintenant, au finish, quel protocole ce patient a reçu pour pouvoir continuer son traitement? Merci.
Okay, so we'll take the responses. Let me add one one question to you. So you mentioned it's a very low resistance, though you saw some mutation. And we know some of the resistance profile for DTG. But in your recommendation, do you think that we should rather look at the potential other adverse reactions or side effects of the medication among your clients, in addition to just the resistance? And then please answer the protocol you are using to assess your resistance. So thank you very much. Dr. Chuma, please go ahead. You had a lot of questions.
Thank you. On the first question where you were asking about the regimens which these clients were on, majority of the first line clients were now on DTG-based regimens since the introduction of DTG in the country. I think it was in 2019. Then we had a few who were still on a 5-rinse-based regimen because of some special reasons. Then in terms of TB preventive therapy in the country, yes, we have a TB preventive therapy program that is ongoing and is available in the public facilities where we use 3 months of isoniazid rifampicin, and also we have the option of daily isoniazid. So the program is there. However, TB remains a predominant cause of mortality. We actually have a significant number of people who suffer from TB. I would not comment on whether the rates are declining since the introduction of TPT or not, but it was introduced around 2019, 2020 in the public health sector. Then, apologies, I didn't get the third question, your third question. Sorry.
Therapy, the duration of therapy. And the cancers,
one I got.
yes,
Okay.
the duration of
All right,
that.
in terms of cancers, top on the list, majority of our clients who died of cancers actually had cervical cancer. So it were the females. So it was cervical cancer. Off head, I can't remember which was next, but I remember the top cause was cervical cancer. Then duration of therapy, we had, remember I said pre-ART and ART. So we had some who were on week 0 in terms of antiretroviral therapy. But for the other clients, we had clients who had been on ART for even more than 10 years. So we actually had elderly people in this cohort. I think I've answered everything.
Okay, so
She has not answered the question on meningitis.
meningitis, the
Oh, okay,
cryptococcal meningitis. Have you adopted the recent WHO guidelines for management of cryptococcal meningitis?
Okay, so in terms of management of cryptococcal meningitis, we're screening all the people who have a CD4 count of less than 200. We're using a serum Craig test. So we do a reflex test. When someone gets a CD4 count done, if it's less than 200, reflex serum Craig is done. And then when they come out positive, we refer for a lumbar puncture, but at the same time, we commence on the treatment on fluconazole therapy. So that is what we are offering. Thank you.
Okay, so before I turn the mic to Ondo, can you tell us, you see the renal conditions you saw, can you tell whether you think it's related to previous exposure to tenofovir before you switched to, DTG, or what were the baseline parameters which could be causing? Is it drug related or what? Maybe if it was identified earlier before they started ART. And then whether you have a cervical cancer HIV screening program, in Zimbabwe as policy.
Okay, thank you for that. The renal failure patients, in as much as in this analysis we didn't look deeply into it, we have quite a number of clients who have renal failure secondary to TDF. Then some, it would be renal failure from HIV, the HIV-associated nephropathy. Then in terms of cervical cancer screening program in Zimbabwe, yes, it is available. But maybe just to put you into context, Mpilo Center of Excellence is a referral facility. So we receive patients who are coming from clinics where they don't have cervical cancer screening facilities. So which means the type of clients that we see are already having advanced disease, whatever the condition is. So at our facility, cervical cancer screening is readily available at the facility. We don't need to refer them to any other place. But these are clients who came from other facilities. Thank you.
Thank you very much. Dr. Ondo, over to you, please.
Merci pour la question. Ce que nous pouvons dire par rapport à ce patient, nous ne faisons pas le suivi du patient à notre centre de recherche. Cependant, nous formulons des recommandations aux médecins traitants. Et donc, suite à l'émergence de la résistance, nous avons formulé aux médecins et selon les protocoles mis en place, il est recommandé, dans un premier temps, de mettre le patient, au lieu de prendre DTG 50 mg une fois par jour, mais plutôt 2 fois par jour, ou de changer le traitement et de basculer en deuxième ligne pour ce genre de patient. Donc là, présentement, je ne peux pas dire si le patient a été mis en deuxième ligne ou a été renforcé. Parce que nous savons qu'après l'émergence, nous avons notifié aux médecins traitants qu'il y avait une émergence de résistance au traitement chez le patient.
Do we have more time? Hello. Do Do we have more time for? We have 1 minute. Okay, so I think if we have 1 minute, can you hear me? Right. If we have 1 minute, let me take the opportunity to summarize. And first of all, to thank all of you for being here, to thank our presenters for the insights they've shared with us. It's very clear that as countries, we have to begin to now implement clear models for advanced HIV disease. We're having an HIV aging cohort on treatment. And it's very important for us to be able to establish a surveillance of key indicators, non-communicable diseases, and adverse reactions associated with the medications that we are giving to these clients, so that whilst we are addressing one problem of immune reconstitution, we preserve the lives of the people living with HIV by protecting them from these age-related conditions. So we know that in the West and Africa region, and among women and blacks, there is obesity associated with DTG. There have been studies in other settings, including Ghana. And so how do we deal with such situations? How do we put in place protocols, maybe nutrition guidelines, to be able to address it so that they don't come down with a complication